We are here in Dr. Carola Eisenberg's home, also with Dr. Klein from the History Committee of the American Academy of Child Psychiatry, on the occasion of the 8th Eisenberg Award with Dr. Shekhar Saxena, Director of the Mental Health and Substance Abuse Department at World Health Organization, who is the awardee for 2017. Congratulations, and thank you for joining us for this interview. It is a pleasure to talk to you. Welcome to Boston. Welcome to Cambridge. I wanted to begin asking you to tell us a little bit about your background, where you were born and grew up, and to tell us about, some of the memorable things during your childhood. I know that it's a period people who are watching this will be very interested to learn about.
Thank you very much, Karim, and it's such a pleasure and privilege to be here. And I'm deeply honored by you selecting me for the award, and also to be able to meet Carola Eisenberg. I have respected Leon Carola for a long time, and more recently I have talked to people who were much closer to them as a couple than I ever was. And what I have heard is extremely inspiring. So I'm really privileged to be in the company here, and also to visit Carola in her apartment and to be able to speak to you. I am a psychiatrist, as you know, by training, and I come from India. That's my home country, although I'm based in Switzerland now, in Geneva. I was born in India, in the northern part of India, and had my early schooling in central and northern India, in towns like Gwalior and then in Bhopal. After my initial schooling, I joined medicine. That's what my first love was, and also my parents' choice, because at that time the children went with what their parents expected them to do. I came to Delhi in an institute called the All India Institute of Medical Sciences.
Before you get there, I want to ask you about, you went to the university as an undergraduate in Bhopal?
Yes, that's right.
And then you were a gold medal winner. So you were a really highly successful student, undergraduate, right?
I did my first degree in science, Bachelor of Science in Bhopal University, and I was studying biology, and that was perhaps the first time that a student from the biology stream got the highest mark, and I was given the gold medal. Because usually the marks given for people who did mathematics were much higher than people who did biology. So I was very proud to receive the gold medal in my first degree.
Was it the usual progression to go to medical school? Because is it you, as an undergraduate, you get into medical school, but you did a first degree, bachelor's degree at...
Yes, that was unusual for one to do a first degree in science before one went to medicine in India. And the reason was very strange, actually. I was underage. So to join medicine, you had to be 17 years or more. And actually, I was 2 years underage. So I had to do my whole degree before I could even qualify to become, to join the medical college. So how old were you
when you finished the Bhopal University?
I was 17 when I finished the university first degree. So after that, I could join medicine.
See, now we know. And then I want to ask you about the All India Institute, because everyone has heard about the All India Institute of Medical Sciences, and tell us about in New Delhi, how was it like to get into that school? Because India is a very big place, as we all know. So,
well, India is a big place. I wanted to do medicine, so I applied in 3 competitive processes to join. The usual medical colleges, the Armed Force Medical College, and the AIIMS, the All India Institute of Medical Science. All others of these institutes had much larger number of seats, but All India Institute had only 35 general seats, and about 100,000 students applied to get in.
For 35 places?
For 35 places. And so it was just a matter of chance. I did not expect to get in there. I actually went and joined for 2 days the Armed Force Medical College because I never expected to get into AIIMS. But then when the list came out, I found myself there. And very quickly I had to decide and move because that was a very prestigious institute. And I really loved to be there. So I joined that.
So do you have any understanding of, because we are always in the process of, I always say it's the most challenging thing is how you select people into a program because, because you also have value added by the program itself, but also it's the value that is brought by the people you select. And that's very important for the peer group. And I was wondering, how do they select 35 out of 100,000? That's really a formidable task. How did they select this group? Do you have any idea?
Well, at that time, this is quite a few years back, it was just based on a written exam. So they did not know. It was
based on a written exam.
They did not know the students they were taking.
Narrative, like essays or.
It was an objective type question paper.
I see.
And one had to really attempt it in a very calculated manner because there was negative marking. So for every wrong answer, you get penalized. And so one has to really see how much one knew and where to make a guess versus not. And apparently I must have done well because I got in. Being in Harvard, I think that's a very interesting question because also Harvard selects the best of the people and also grooms them well. So it's a matter of who you get and what environment you provide to do that. And I must say that AIIMS was one of the best environments that one could have hoped for. A small number of students, a very large number of very prestigious teachers, and a lot of good mentoring, which is what makes good students. And I was lucky to be there, and I really loved and enjoyed my time there for 5.5 years of my graduation. That was the time.
So that would be one of your best educational experiences?
That was definitely one of my best educational experiences.
And this is also one of the most important time in your life because that's where you met Abba, who's also with us today, who's also a medical student at AIIMS, right? It was
a very good time for me and also my formative years for my medical training, learning and discovering the secrets of body and mind. And also then meeting Abha, who became a close friend and then wife.
Did you get married after medical school? Or
we got married after medical school when, in fact, when I was doing my psychiatry training at that time, we got married.
So when you declared to Abba that you were going to do a psychiatric training, how was it? What was your reaction?
I don't think anybody was happy with that choice.
Especially in India.
Psychiatry certainly was not one of the most coveted subject to join. And my professors, my fellow students, and my family members all questioned me.
Right.
Was I really interested in psychiatry that much? Did I have other choices? And I said, no, I have only one choice. And but
when did you decide? When did you decide?
I decided during the last 2 years of my undergraduate period.
What do you think is the most convincing explanation of why you became interested?
I don't know the explanation, but I can say that it was certainly because of my psychology and psychiatry teachers who were really very, very influential in developing a curiosity about mind, which really intrigued me. And I found myself spending a lot of time reading books. I had a whole collection on Freud to begin with, even before I joined psychiatry. And I was very intrigued by that, very fascinated by that. And also some of the patients that I saw even during my undergraduate period really posed a very serious amount of challenge, which I found very interesting. And that was my only choice, and I'm always very happy with that. But it did require a bit of convincing my family members and also Abha that this is going to be my profession. there is stigma against mental illnesses, but also there is a stigma against mental health professionals.
Right.
And at that time, it was even more than what it is now. So it was challenging, but I'm happy that I selected that because...
were you the only one in your year that selected psychiatry, or there were others?
There were 2 other people actually. So it was out of 35, we were actually 3 who selected psychiatry.
That's
and
amazing.
one of them, one other person pursued that career, and he's still a very close friend. So, so that's really a good part of my life.
You know, I've heard it said that quality of medical education is correlated with the choice of number of people choosing psychiatry in medical schools.
That certainly was very true for us, because we had some excellent teachers in this area, and also the attention given to students was so good that we could explore a number of areas beyond the course curriculum, which is what interested me in psychiatry, and I was very lucky to be exposed to that kind of environment.
Well, you have something in common with Leon Eisenberg here, because he graduated from University of Pennsylvania Medical School, and he was top of his class, and he chose to go into psychiatry, which was always interesting because he could have chosen any field. But so the psychiatric training, after 5 years of the AIMS, you went into psychiatry, and that was like 3 years, 4 years?
It was 3 years of what we call junior residency, leading to the final degree of MD in psychiatry, they call it. Right. And then 3 more years of senior residency, which was further training before you joined a faculty position. So it was 6 years of training in total.
And what kind of places did you spend time, like were there any institutions at that time, or was it mostly general hospital-based psychiatry? So it was a whole range. Can you tell us a little bit about how psychiatry training was like?
Much of it was in the general hospital setting in AIMS, where we had outpatient, inpatient, some special clinics, but also a part of our training was in a rural setting.
I see.
Where all the students, all the trainees go there to be exposed to some of the environment which is not in a large hospital. And that was also very interesting, because we could teach undergraduate students and also practice in an environment that was much more community-based than a hospital-based environment. We also had a short training in a mental hospital nearby. And that was the most eye-opening experience for me, because the situation was extremely bad. The care of patients was simply not satisfactory at all, in terms of the basic facilities, but also in terms of the treatment provided. And that really affected me a lot, because I thought, in this era, in this time, if we are treating some of the people who are mentally ill so badly, something must be done very urgently. And those images, those thoughts have never left me throughout my career.
You know, Carola, you also, when you were telling me earlier in one of our interviews that your father took you to visit a psychiatric hospital, right?
Yes.
And you were very much affected by that.
Yes, I was very young and I was very much affected. It was a public lecture, and it was the first time I went through words that were like Dante's Infernos. And at the end of the lecture, people went to ask the speaker questions. And at that age, maybe 17, I heard myself, shy as I was, and I said, is there anything I can do for the patients? Because the others were asking stupid questions, like, are you afraid to sleep because we heard that mental illness is contagious? Are you, to the director of the hospital? So that got me started in a new career as a psychiatric social worker. Yeah? But then I went to medical school not knowing that I wanted to do psychiatry, right. But it was somewhat similar to your experiences, only that mine was 30 or 40 years earlier than yours.
And of course, with all this stigma goes all sorts of beliefs about how mental illness and what causes mental illness and contagion effects and all this stuff. So, so you finished your training. You then go to London for diplomate in addictions.
So, Karim, after finishing my 6 years of psychiatry training, I joined as a faculty member in the same institute, and I was very lucky to find that position, which again was in my professional life a very interesting period, because I was doing a number of things. I was seeing patients and treating them. I was teaching, and I was also doing research. And I became more and more interested in public health kind of research, which is what I liked quite a bit. So I worked there for about 6-7 years as a faculty before the opportunity came for me to go to Institute of Psychiatry in London for a year to do a diploma in addiction behavior.
So this is the British Council scholarship?
That was a British Council scholarship, and I joined Institute of Psychiatry for 1 year. I was again a student after a number of years working as a faculty, and I specialized in addiction behavior.
So where were you in London?
I was in the Institute of Psychiatry, Maudsley Hospital.
Maudsley,
which is,
in Camberwell, Denmark Hill.
Absolutely, Denmark Hill.
Yes.
Yes, and I remember it was the addiction unit was in Porta Cabins, and it used to become very cold, so I used to have to wear coat and socks and shoes being inside the building.
Yes.
And but it was a very interesting, very nice.
Were you with Abba at the time? Did she come with you, or were you alone?
Abba came after 6 months, so she joined me for 6 months of that 1 year period. In fact, she started working, so I could not have afforded to stay there on my students' allowance. So actually, Abba earned the money for me and our 2 children to be there for 6 months.
So now you have something in common with me. All right. So, so tell me about Maudsley in 1989, 90, and you're there at this incredible institution. And so there are a lot of very important people in psychiatry, right?
Absolutely.
Yeah.
My immediate unit chief was Griffith Edwards, one of the stalwarts in this area.
Right.
But being a student and having no clinical responsibilities, I made very good use of the excellent teachers in other departments. So I attended all the grand rounds, all the lectures, and many of the teaching sessions where I was not expected to be, but I just went and sat there to listen to and learn from people who were around, including very famous people, David Goldberg at that time,
of course,
and Michael Rutter. There is a building in Institute of Psychiatry called the Michael Rutter Building, and I was just next to that. So it was an enormously good experience to listen to some of these people, read their papers, and actually be able to discuss things with them. It was very, very good.
So how did they treat you? I mean, how was your experience of how you felt collegially engaged, included in the institute? Like, because you were there only for a year.
Yep.
And so how was the experience of having being a diplomate of the addictions program? And
the diploma is, and perhaps now it's called MSc, but even now it's a very international one.
Yeah, so there were a lot of international
There
people.
were 9 students, and 7 of them were from outside UK.
Right.
So it was very international. I was very much a part of that international community. And Institute of Psychiatry, I felt, was very cosmopolitan, very integrated. They had no problems in talking to and mutual learning from people coming from all over the world. So I found it a very enriching experience and really enjoyed it a lot. It was fascinating that the UK people, including the faculty, had a lot to teach. But we brought our own experience to the classroom. And having worked for several years in India, I could actually contribute quite a bit to the debate about the models of care, the most efficient use of resources, which we were doing because we had to do that. For example, I was seeing almost 60 to 80 patients on my average outpatient session in a day, when my UK colleagues were seeing perhaps 4 or 6. And so how to make a diagnosis within a very short time, how to start the treatment, not having a full team of a psychologist and a social worker and other colleagues was something which I was quite accustomed to do. And of course, I learned better therapies, but I also could discuss the most time efficient and resource efficient way of working. So it was a very, very good experience for me to interact with the people there.
So there was, as always, this kind of learning. Global experiences are like a two-way road, isn't it? And so you have still got connections from that period. Have you?
Absolutely.
Yeah,
in fact,
right.
I am fortunate to go there almost every year and interact with people, and they come over to WHO where I'm working now. So it has been a very fruitful experience and collaboration.
So was this choice of the addictions psychiatry serendipitous, or was it something that you really wanted to do, the addictions and behavior psychiatry rotation?
Well, it was very timely because in India, the addictions, including the excessive use of alcohol and dependence, were just becoming very visible at that time. So from middle 80s, where I was practicing, these problems were just growing very fast. In fact, I wrote the first paper on heroin addiction in India at that time. And that paper was published in 1984. And so it became my interest to look at this newly arising problem, which was devastating a number of young people in a city like Delhi. So I was curious. I wanted to increase my expertise in this area. And fortunately, I got a scholarship, so it became possible for me to go. And so I utilized that opportunity and specialized in this area. Of course, I did not leave general psychiatry, so I was still involved in all the other kind of patients. But this just increased my capacity to respond to this new challenge that was very obvious in a city like Delhi.
Were your daughters born at that time when you were in London? Or?
Yes, in fact, when we went to London, when my wife joined me, she came with 2 of our daughters. One of them was 5 and another was just 1. So we had 2 young kids in this big city of London. And my wife working and me studying, it was quite a task actually to look after the 2 young kids.
Right. Right. And so that lasted about 12 months experience?
Yes. My stay was 12 months and my wife and kids' stay was 6 months.
Huh. You know, we run a program with NIH where we bring people over, and I think that this experience of I have a colleague with me here also that 6 months or 8 months or 12 months, it's such a formative experience. It's to go through that kind of an exchange. And,
absolutely, I agree. In fact, perhaps 2-3 months is too short for one to settle down and learn. 1 year, 1.5 years is, I think, an excellent period. But I also feel that much longer than that is also counterproductive.
Right.
Because you keep a person for 2 or 3 years' time, and the person never goes back. And I'm very aware of the scarcity of highly trained professionals in low and middle income countries. And of course, it's good to train them, but it's not good to absorb them.
So here we have the director of the mental health unit at WHO, who's essentially endorsing this idea. So if Fogarty or Wellcome and other institutions are hearing this, they should really support these kinds of exchanges, like this kind of intermediate term exchanges for scholars.
Absolutely. There is an increased need now, even compared to earlier, for capacity building in low and middle income countries. And this could be done in a manner that makes them more independent, makes them more skilled, but they must go back and serve the country and the community that they came from.
Right.
Of course, the onus is also on those countries to provide the kind of environment that is needed. But brain drain, especially of people who are so much needed in their countries, is absolutely counterproductive. It increases inequity. So the key is to provide the kind of training and mentorship that is necessary, but still not encourage people to move out forever, because
Right.
that is a very tremendous loss of precious skilled manpower for the country.
And also sustain the support in the country as much as possible.
Absolutely. In fact, the initial period of training outside the country should be relatively short, but the support and collaboration must continue after they go back.
Right.
And that is extremely important for increasing the capacity and making it very sustained.
So how was for you when you re-entered back into the AIMS? You went back to AIMS after the...
That's right. I went back to AIMS, and I was again very fortunate that they kept the position, so I could go back to my earlier position and practice some of the newer skills that I had learned. But also I could connect to the Institute of Psychiatry continuously. In fact, they appointed me as assistant editor to the journal, the famous journal Addiction. And so that also provided me with an opportunity to look at the most recent research, to correspond and to sometimes write. It became a very nice ongoing capacity building exercise for me. And I could train some students in the kind of things that I had learned. So it was extremely beneficial not only for me, but also for the institute that I served.
So I think David Klein has a question for you also.
It has to do with keeping up to date with progress in various fields, and particularly in addiction psychiatry. In America, we're now having to repeat the examination every 10 years to prove your competence in keeping up to date. What happens elsewhere in the world in that matter? And do you have opinions on how one is best kept up to date in the field that's advancing quite rapidly as we're studying this brain disease of addiction?
Absolutely. We as professionals need to update our knowledge periodically so that we can learn the newer theories, but also newer techniques to be able to serve the patients and to teach in a manner that is appropriate for the current times. And the increase in knowledge is so rapid now that there is increasing need for a continuing education throughout our professional career. It's not the same way that you used to train doctors and they serve for the next 30, 40, 50 years using the same knowledge. That's exactly not the case now. But I have a concern that if the professional societies are not able to keep up with that kind of function, then the vacuum that is there is filled by, for example, commercial organizations like the pharmaceutical companies, which organize the kind of training that suits them and influence the way doctors work, the kind of medicines that they prescribe. And that is something which is not in the best public health interest. So professional societies as well as the institutions that have primarily trained them have a responsibility to continue with the education.
Yes. And what is your opinion about examination, a formal examination, a written examination to demonstrate current knowledge base? There's quite a debate here in this country whether an exam is the best way to do that.
Exams are necessary but not sufficient. So my feeling is that a continuing training and skill development along with some mentoring and some process of monitoring what kind of knowledge you have acquired and you are actually practicing is perhaps much better than a written exam. which just tests a few of the skills and perhaps more knowledge than skills, and is not quite sufficient for checking whether the person is keeping up to date or not. And in medicine and psychiatry, it's the skills that are more important than just the knowledge. An additional point is that one should also check the knowledge about how you are able to do the updating based on the research papers that get published. So your ability to read, to understand and get the right messages from written research is something that we should test very much more. Rather than just testing knowledge, it's the way of acquiring knowledge that also should be tested really.
Very good point. So let's. So you continue your career development. You're advancing at the AIMS, and then in 1995, and you're doing the editorial stuff and teaching, and in 1995 you become a medical officer at the World Health Organization Division of Mental Health. Can you tell us a little bit about that and how that happened?
In fact, my association of working on WHO projects started in early 90s before I really joined WHO. And I became more and more fascinated by some of the work on public mental health, which WHO was leading. And I became involved in some projects. I did some extra work there. I was also involved in development of International Classification of Diseases 10th edition, which was being developed that time, the ICD-10. And that brought me in contact with some of the people in WHO, which was very interesting. And I felt that while treating patients is of course very rewarding, and I really enjoyed that, sometimes changing the system has perhaps a much larger impact than caring for patients one after another. And that brought me in more close contact with the WHO's vision of changing the health system in such a way that more and more people could access evidence-based treatment rather than just to provide the treatment. And so I worked on some projects. Then in 95, a situation arose that I had the opportunity to come to WHO in Geneva for initially just 6 months' time, which actually became 1 year. And I realized that I could actually live without seeing patients every day. And it still could feel satisfied in doing what I was doing.
So these patients that you were referring to, I mean, you were still seeing many patients every day, like up to 60 or?
In Delhi, I was seeing patients every day.
So it was exhausting?
It was my primary responsibility. If a patient is waiting, you can't be doing other things.
Right.
So that became my primary responsibility. Of course, I was teaching, I was doing research, and also I was advising the government for some of the policy aspects. But patient care was my primary responsibility, and I took that very seriously. And
there's a significant shortage of personnel.
Absolutely. In a country like India and many other low and middle income countries, the number of professionals, especially in the area of mental health, is so deficient that each and every professional is working a lot, and still the demand cannot be fulfilled. So I was doing what I could, but WHO really fascinated me because there were many things that were being developed there to guide and advise countries like India and other countries in the best possible manner that they could reform their mental health system. For example, not increasing the number of mental hospitals and establishing psychiatry units and de-addiction units in general hospitals, which is where I was working. And those kind of things had to be done much more systematically and much more, including financing of those general hospital settings, making general hospital psychiatry much more acceptable to others. I remember that the psychiatry ward in my institute was always very difficult to manage, because sometimes patients will just walk out and enter some other ward. And we used to receive a phone call to saying, your patient is in my ward. What is he doing there?
It's your fault.
It's my fault.
Right.
So I had to look after patients and also make it sure that nobody else had this problem of mentally ill patients being treated along with physically ill patients. But we made it successful. We make it acceptable. And that's what we wanted to do in the whole country. And that required some policy changes, which is where WHO was taking a lead. So that made me much more interested in the kind of
So
public
this is
mental health.
in the mental health department at WHO?
That's right.
And this was at the time of Norman Sartorius?
This
or?
was at the time of Norman Sartorius and also John Early, who was there at that time.
John Early.
And so it was again a very good experience for me to come to WHO for 1 year's time, learn the kind of things that they were doing, and I decided to go back just to see whether whatever I have learned I could use within the country, and I served for another 2 or 3 years' time.
So you returned back for about a couple of years and then came back, and this time as a scientist.
Yes, I came back in 1998 as a scientist. Again, it was for 1 year period to begin with, but then it became 2 years and 5 years, and now it's 18 years.
Many years. So tell me about how you made the transition once you came back into a full-time position. This was in the in the classification, assessment, and epidemiology group. That's doing a lot of analysis, and you had some background in the statistics, or when you had training, you obviously had in biology and AIMS, and you had very good training. So tell me about how biostatistics and epidemiology enters into your training, because some people argue that that is really very important in the education of physicians these days. Ethics, epidemiology, and biostatistics. I know that, I don't think it's too controversial to say that now, but it used to be. So how did you develop yourself in those areas?
I did not have a training especially in statistics, but I was certainly very aware of the epidemiological aspects and also on structured interviewing techniques as well as some of the instruments. And WHO at that time was taking a lead in developing instruments and testing them across cultures.
This was the present state exam?
That was the present state exam, PSC.
John Wings.
As well as, yes, exactly. As well as a disability instrument called the WHO's disability assessment schedule called HUDAS. And also WHO-QoL, which was on quality of life, where I worked on these projects to compare data from different countries, and essentially to make a point that it is possible to compare people across cultures, across countries, using the same metric. There was movement there at that time to say everything is culture, we can't compare people, we can't compare diagnoses, we can't compare interventions. And WHO's view was that yes, there are cultural differences, but it's still the same instrument with some adaptation can be used across cultures, and data can be compared across cultures. And that was which had to be proved, had to be demonstrated by actual data. And we did that. We made an instrument, HUDAS, which was cross-culturally applicable for assessing disability amongst people of people with mental disorders as well as addiction disorders, and we demonstrated that it was possible to do so. EPI is of course very important for mental health professionals, because unless we know what kind of problems are there in a particular community and what are the determinants of those problems, it is extremely difficult to make large-scale changes. You can continue to treat patients, but if you really have to go to prevention as well as promotion of mental health, you need to understand what are the factors which are leading to it. And those are the kind of things which WHO was doing at that time. So I was very fortunate again to be joining WHO at a time that some of these very controversial aspects were proven or disproven by data.
Right. And this is a very important period in psychiatry because, also in the United States, because we have this incredible transformation of, the use of reliable and validatable instrumentation and an emphasis on classification and nosological distinctions and subgroups and so on, and trying to see if they can improve outcomes and so on. And so this is a very important period. And this is a period I wanted to know because you were saying also that you met Leon Eisenberg in Geneva. You were introduced to him. So maybe you can tell us a little bit about that, how that happened.
Yes, I was working in WHO starting from 1998, and I was looking after a number of projects as well as then assisting the then directors. Began with Norman Sartorius, but also then had other very, very effective people as my directors. Benedetto Saracino was my director towards the later 10 years of my period in WHO. And I know that Benedetto was very much close to people in Harvard at that time with Leon Eisenberg as well as with Arthur Kleinman. Yeah. And they visited us for several meetings and several other consultations. And I was very lucky to meet Leon Eisenberg in Geneva on a couple of occasions. I don't think he would have recognized me, but I did, and benefited from his presence, from the kind of consultations that he had. Towards the end of that period, in fact, we made the Child Mental Health Atlas, which Myron Belfer, who's also in Harvard, helped us to develop. And Leon Eisenberg wrote a one-page foreword for that. And I still remember we gave him the draft of the atlas, and he wrote that foreword. And we said no more than one page. And he still could pack all the important messages in that one page, including quoting a poem on the child. And it was very fascinating to see that. We did not have to change a single word. It went straight from his pen to the printers. And even at that time, it was a remarkable feat to present the world situation on child mental health in a few pages. And that document still is one of our very often read and often quoted document.
So this period of a decade that before you became the director was a very, very productive decade for you because you coordinated a lot of activities for WHO that became very important in the history of mental health, global mental health.
It was a very important period for me as well as I suppose for mental health.
So you deserved to be the director, but those 10 years was a really, that's sowed the seeds of that work that validated what you were, and in a way it's such a nice thing that you were selected as the director of the mental health because that you really had done a lot of yeoman's work.
I don't know about whether deserving or not deserving.
I'm just looking at the facts.
But yes, we made a lot of progress. Fortunately, we had a very nice team led by Dr. Saracino, but also a number of colleagues who helped us to really shape the kind of advice that we were giving to the governments. Before that, the emphasis was on collecting data, doing projects, and demonstrating that mental illnesses are there in every country. There are good interventions that can be applied, and helping people to do better psychiatry. What we did in the last 15 years is actually to advise the governments to change the system so that those effective interventions could actually be delivered at a scale. And that is something which I think was absolutely path-breaking in some way, led by my earlier director, Dr. Saracino, where we emphasized that human rights in mental health care are extremely important. Care should not be given in mental hospitals. It should be in community settings that care should be given. And also that equity is extremely important. we need to deliver care to whoever needs it rather than only to those people who can afford it. We need to spread the care to everywhere, not only in urban areas but also in rural areas, and also at all age groups. That's where some of our work on child mental health started, because we were focusing earlier on just adults, and that was no more acceptable because we realized that majority of mental illnesses actually arise during the childhood, and we were just ignoring that. So that was the period where our work became more comprehensive, more policy oriented, and the focus was on how to provide the most effective care to the largest number of people. So it became a much more public health oriented advice that we were giving. It was not only excellent care, but more care to more people. And that became really very fascinating work to lead. And I'm very happy that a number of countries are now paying much more attention to these kind of aspects. And the movement is growing every day.
Well, this is, one also notices this actually during this period, because we had Benedetto Saracino come to Istanbul and visit with Ihsan Doramaggi. It was at the Public Health Association meeting. It was the last 2 years of his life. He was one of the living people who signed the Declaration of Human Rights for the United Nations. And it was a very memorable occasion. And my colleague here in the room with me was with me at that meeting. But I also noticed there is this human rights, and there was this passion for people. There was this caring for human beings. It was also not just, it was like there was this sense of like there was a heart also with this. And I'm also glad you mentioned about the children, and because the majority of the population pyramid, in these countries is. Tell me about our good friend Myron Belfer, because he was a very key figure in terms of the years that he was advising in the child mental health section and WHO, and some of the work that you were doing with him. And so how that.
In fact, it was Myron Belfer who decided to come to WHO and spend a couple of years with us. Those couple of years became actually 4 years. 4 years. Which was very nice. To get such a senior person, such an experienced person in the area of child mental health over to WHO was absolutely very fortunate. And he actually sowed the seeds for our child mental health program. We gave it the kind of importance that was increasingly needed. And he did a number of activities by collecting data, by making it available, and also in a way giving the life course as one of the fundamental cross-cutting principles for all our activities. We did not want child mental health as a separate discipline. We wanted to integrate child mental health in all our activities. So when we go in and advise the governments, we didn't want them to develop a specific, say for example, institute in child mental health, but integrate the children's aspect in all their activities. And he helped us to do that. He also did a bit of research. He advocated for that kind of issues. And he was, at that time, a very, very good colleague.
Did WHO always have a child presence, child mental health presence?
Not before he joined us.
Officially, yeah.
So he was the pioneer in that sense to help us to develop that kind of program. And I'm very happy to note that even after he left, he has been continuously helping us. And we now have one full-time person on child mental health, and also have
Dr.
the constant, Dr. Saivali, and also have Myron's advice continuously with us. In fact, it has become a regular theme for us to have child mental health as a part of our MHCAP forum, the event that we organize every year around the World Mental Health Day. So that is something that we are increasingly attending to, and definitely there is much more need for that.
So let's get to the MHCAP, because this is really very, very important, and I think everyone who does psychiatry has to know what MHCAP is and what MHCAP did. So tell us how it was started. How did the MHCAP start? I think it's around 2010, so you're becoming the director at this time. So maybe you can tell us about the MHGAP
In
and then
fact,
the Millennium Development Goals. And
It started actually in 2008 when we
2008.
began the project called MHGAP, which stands for Mental Health Gap Action Program.
Right.
The basic philosophy behind that is that there is a very large gap in mental health between the needs that are there and to the extent those needs are fulfilled. So if 100 people need help, if only 20 are receiving help right now, then the gap is so large, 80%.
Right.
And we need to fill that gap, and that's the public health approach for mental health. We selected 8 conditions out of mental, neurological, and substance use disorders, which gave rise to the largest amount of burden
Right.
because
So that
of
was
these
related
conditions.
to the global burden of
Absolutely.
Yeah,
The global
disease
burden of
index.
diseases provide us the
Yeah.
fundamental framework for this approach.
Sure.
To say that if we can really do a good job of treating and preventing these 8 conditions, then we are being successful. And out of these 8 conditions, 4 were in the area of mental health, and it included depression, psychosis, child mental health problems, and suicide prevention. We included child mental health simply because we realized in the earlier few years that children have to be attended to, not only for treatment but also for prevention and promotion. In fact, if we start intervening during the childhood, the future disabilities are so much decreased. So we included that in spite of our realization that the knowledge base in child mental health is somewhat on the poorer side.
Right.
But we had to do that. And so we included that, and we prepared what is known as the MHGAP Intervention Guide, which is to guide clinicians who are non-specialists, general doctors, general nurses, psychologists, and other professionals who could provide the kind of care that is needed for these conditions with support and supervision of some other people who are specialists. And this guide now, which we published first in 2010 and the last version in 2016, is extremely successful because it provided the kind of technical support that the countries needed. And now it's being used in more than 90 countries. It's translated into more than 20 languages. And all of these material are available on our website. So we didn't want to keep it to ourselves. We just gave it to people, whoever wanted to use it. And even the child mental health module is being used in a variety of countries where the number of child mental health specialists is close to 0. And even mental health professionals are very few. So this provides the mechanism by which anybody who's there in that country, any professional in the health area, could actually acquire and use this knowledge and skill to provide the kind of treatment that is necessary for children in these situations. And seeing that children are a large percentage of population in some of these countries, and also the prevalence and incidence of child mental health problems is high and is increasing. This was very much necessary, and we are very happy that this
as the childhood survival is improving.
Absolutely.
Also, yeah. So, and I think there was this period also before the MHGAP that there was this WHO mental health policy era where there was a lot of these, and we used it actually in our work to create the National Mental Health Policy of Turkey, and we integrated the child mental health in it. That's a very important integral part, but all the other disciplines as well, like pediatrics, nursing, and so on.
Absolutely.
Yeah. So the then there is the Lancet series that is starting brewing, you know, like in 2007, 2011, you're editing and doing so. Tell me also a little bit about your interactions and overlap with the work of Vikram Patel, and who is very important, of course, in the global health, mental health movement. How did you work? Did you work together? And I know that he was involved in the Lancet series as well. So.
Yes, in fact, I've known Vikram for almost 20 years now.
Okay, great.
And also being a fellow Indian and a fellow mental health professional, it has been a very, very collaborative period of working with him. We worked in a very focused way for the first time for the Lancet series of global mental health in 2011, where the work started actually in 2005.
Right.
It was, I think, the time for global mental health had come at that time. So Lancet, on its own, invited me and Vikram to edit this special series. And we could collect a number of professionals from all around the world to really contribute to it and see what are the key messages. Well, to begin with, key challenges, and then the key messages that we need to deliver to the policymakers about global mental health. And it was a very intense period of work, collaborating with a number of top professionals in this area and writing 5 review articles and 1 call for action, which actually became very influential at the end, because our key message was scaling up mental health care is the top priority for global mental health. And at that point, I want to remember what Leon Eisenberg said about these things. In one of his quotations that I still remember very clearly, he says that when the sickest of our patients required our help, we were discussing whether environment or genetics is the cause for these disorders. And we were discussing who should treat these people rather than to actually go out and provide the care these people need, which is what really encouraged us to have this call for action, that at this point of time, even if we do not know the cause for many of the mental illnesses, we know how to treat them, and let's focus our attention on that kind of exercise, which became a very practical and utilitarian view of looking at global mental health rather than to look at discussing the theories behind them. And that's what the call for action for Lancet series in 2007 was. And we were very pleased that a number of countries actually paid a lot of attention to this. And at least there was a growing movement for scaling up care, which was absolutely necessary. Beyond that, Vikram, who's a close colleague and friend, and also has just joined Harvard a couple of weeks back, our collaboration has been very fruitful. And in fact, after the Lancet series 2007, we co-edited the 2011 series. And at this point of time in 2017, we are working on a Lancet Commission on Mental Health,
2018,
which will come out in 2018.
So there has been a lot of emphasis now and shift towards mental health and inclusion of mental health and inclusion of the discussion on not just in ministries of health, but ministries of economics and finance. And so tell us about the Sustainable Development Goal era that's is now emerging, and also the work of the World Bank Group and some of the other major organizations that are coming together to sustain these grand challenges and then providing more funding for mental health research and services and implementation science. It's a lot of stuff I just said, but there's a lot going on in mental health, and I think it's confusing in some ways for people in global mental health. There is the area of scale-up implementation science in the low and middle income countries, and there is the era of the convergence of these leading funding organizations to come up with funding announcements for research, collaborative research and partnerships. And there's also consolidation in many universities, as Vikram is at Harvard now, and of the global mental health groups to address these issues. So there's a lot going on in mental health emerging as a very strong area. The issue, of course, is that we just had recently proposals to scale down NIH by 18%. And among these proposals, the most shocking to me was the fact that it was proposed that Fogarty International Center should be closed and be essentially folded into other institutes. And So I just wanted you, having just heard of what some of the things I was saying, what your reaction to some of the stuff that I'm just discussing.
I think if we go back in time, psychiatry and mental health were not even integrated within the health area. The mental hospitals were located outside the cities. The psychiatrists were not very much part of the medical training, not very much part of the general physical care. They were kind of outcast, and the whole discipline was surviving vertically on its own and in some way disaggregated and dissociated from the overall health field.
Orphaned.
Completely.
Yeah.
That's the right word, actually.
Right.
I think our predecessors worked very hard to integrate it within health. But the time has come now to integrate it within the overall development area. And the inclusion of mental health in the Sustainable Development Goals of the United Nations in 2015, when MDGs had no mental health, but SDGs now have clear inclusion of mental health and well-being within its agenda, I think is very demonstrative of this pattern. So the world leaders have recognized that health is important, but mental health is part of health as well as part of the overall development within a country. And that's a major change. Because we have demonstrated by very clear facts and figures that mental health is so instrumental, so important for the overall development of a country, not only from human rights aspect, but from the economic development also. And that is being heard, that is being recognized and acted upon. So that's a major change for professionals like us, because now the world for us is much larger than our very narrow definition of mental health. And that way I think it has been a major change. And also it is potent to very many important things to happen. We are not only now advocating for mental health to the Ministry of Health, we are advocating for Ministries of Finance, because there has to be an investment into mental health.
Right.
And that will have major returns for us in the coming years and decades. And that is something that not only the World Health Organization is saying, it's also the World Bank that is saying.
Right.
In April 2016, the president of World Bank, Jim Kim, who's a Harvard alumni, and also my director general in WHO, Dr. Margaret Chan, came together in Washington, D.C. during the spring meeting of the World Bank Group to really emphasize the fact.
Excuse me, what year was that Jim Kim met with
Last year, 2016.
16. He really organized and hosted a meeting on mental health. So that was very important event to really put mental health in the overall economic development area. And he made some very nice speeches to demonstrate this and pass a message to the World Bank employees that you need to consider mental health as very important. And that's a major change for us. Along with that, we have this issue of international collaboration, which people like Leon Eisenberg always talked about, that we cannot work in isolation within a country. We really need to become international. We need to collaborate with people, because there is always a bi-directional flow of information and knowledge that we can all gain from. And that's something that WHO is very clearly advocating for. In fact, we have gone on writing to say that international collaboration is not only helpful, but it's absolutely essential for further developments in the area of mental health, because in our view, when it comes to mental health, all countries are developing countries. None of them have got it right, and we have a lot to learn from each other. An experience in a poor country like Mozambique or Ethiopia or Sri Lanka can actually be very effective and very useful for a high-income country like the United States or Germany or France or Canada, because the kind of innovations that are being done by force in some of the low-income countries can actually be very useful for some of the so-called highly developed countries, because even in those countries, the treatment gap is very high. there are a lot of people who are still unserved, and you will not have enough money in any country to really provide the kind of help that is ideally needed. So you need to innovate. And the innovations sometimes come from the very unexpected quarters. And so we have a lot to learn. The low and middle income countries have a lot to learn from high income countries, but the other direction is also true. And in that sense, some of the avenues for further training, skills generation, and international collaboration, the kind of things that the National Institute of Health has done, the Fogarty Center has done, have really served a very useful purpose. And those are the kind of things that we must continue with to see to it that they become the force for mutual knowledge exchange and development, because we cannot really live in isolation. We really have to go out and get the knowledge and experience from wherever that might be.
And I think one, obviously, a key person also in the 2016 meeting, one has to say, is Arthur Kleinman, because he was like the mentor of Jim Kim and Paul Farmer and among other many postdocs that he mentored over the years. So, and it was a very nice tribute to him during that meeting. I was actually there, and your good friend and Leon's successor. So I think what I want to emphasize, that the future, in fact, in global mental health seems incredibly innovative, and compared to some of even the national programs of what's going on. So what's happening in global health now is really almost like a driver of mental health movement in the world, like the global mental health movement. And so I'm very happy to also hear the emphasis in child mental health that we talked about. I want to ask you about a field that I think has been an orphan in global mental health for a while, that suddenly emerged out of nowhere and became a very important force, and that's the field of autism. So, and this is Caroline smiling, of course, because she knows Leo Connor, and Leon Eisenberg was a mentee of Leo Connor. So we sort of, they have the roots in intellectual disability, neurodevelopmental disorders, and autism. So this is an area that is the inception of Leon Eisenberg. So I remember a discussion with Benedetto Saracino about that, and he was saying to me, "What do you think, about this?" And because we need to do something, we need to do something about it. And then you did, and there was this very important meeting, I think, in 2013, right, that you did with Autism Speaks and invited a number of people. And then there was this World Health Assembly ruling, right, which is a very important event where you essentially linked autism and neurodevelopmental disabilities together and made an assembly statement. So so tell me about that, because that's very important developments in WHO. Yeah.
Karim, I will talk about autism, but before that you referred to Arthur Kleinman, and I must say something about him.
Yeah, of course.
Arthur Kleinman has been a very strong force, along with Leon Eisenberg before that, and subsequently other people, to really focus on the global mental health as a discipline. In fact, he wrote the book on global mental health, which became really the most important statement around that. And it started a process which has led to where we are in terms of mental health being in the Sustainable Development Goal, as well as being the focus for the Mental Health Action Plan adopted by the World Health Assembly. Mm-hmm. So I think the visionary persons like Arthur Kleinman have been very instrumental in creating a movement towards mental health, which is based on the principles of human rights, on equity, on access to care, the evidence-based care, and the quality of care that are absolutely essential for any country to listen to. Mm-hmm. And those were the voices which really put the area of mental health beyond just clinical care into policies, into the kind of policies not only within health, but also the public policies that facilitate improvement in mental health for everybody.
Right.
And I must say those have been very, very influential forces to shape things as we see them now.
Yeah.
And that's extremely important. In the area of autism, it
Well,
was not...
before you come to that, I
Yeah.
want to say something about Arthur as well, because, you know, there is a word that I would say that would fit this authenticity, this deep felt authenticity about what we do and what mental health is all about, which is about cultural issues and intellectual commitment and caring and caregiving and being there with people and moral, and then we talks about moral
Absolutely.
commitment that he wrote about, which I think is very inspiring for many people. And of course, one has to, you know, regularly lead the Lancet to really appreciate what he says. And I think hopefully many people in the United States who are training in psychiatry also continue to do the same. I know that medical students know about his work, so I'm very encouraged by that.
In fact, as you talk about the moral commitment, it reminds me of what Leon Eisenberg said. He said, caring for people is not a legal or a fiscal responsibility, it's a moral commitment.
Right.
Now, that's the voice of a physician at heart, to say what I'm doing is not a legal commitment or a financial transaction, it's a moral commitment. And those are the kind of voices which are necessary now, even more than earlier, where there are increasing threats on the practice of medicine becoming much more a fiscal event. And that's where we need to remember some of these things, like Leon Eisenberg and Arthur Kleinman, who have really sown the seeds for these things, which are extremely important.
But I think also one has to say this, and Carola, you can chip in if you like, but one of the keynotes in Doha, for example, the World Innovation Summit in Health in November 2016, which Shekhar was there also, when Larry Summers talks about this grand convergence, which are also in the Lancet series 2025. And with Dean Jameson, the big report. And the issue is that investment in health is not just good for morally, and it's not just the right thing to do, but it's also is the best investment one can make. And probably the same can be said about mental
Karim,
health.
While fully agreeing to that, and we also have now very many modeling exercise where we demonstrate that investments in mental health has a very high level of return.
Right.
And we wrote a paper just last year to say that every dollar is spent on treatment of depression and anxiety
With Tony Evans.
has the return of $4, which is a very good investment. But having said that, and also having used that evidence for anybody who would like to take that support, I must say that I work for the World Health Organization, where we believe that health has its own value besides the economic value of it.
Of course.
So while return is
Good point.
important in terms of dollars, we also believe that health has such a high value of itself that even if there was no return, one would still like to see people healthy. So that's the kind of theory that we have, and I think that's widely recognized as one of the fundamental duties of society, of governments, to improve people's health, whatever it takes. And that's the kind of message that we would like to see happening and being followed in terms of the activities of the governments who have the primary moral responsibilities to provide health and healthcare to its citizens.
Well, I'm glad I brought that up then, because that's a very important point you're making. So, and that gets into this area again of disabilities, of neurodevelopmental disorders, because it's the issue of social inclusion. How do people get included in society in as much functional way as possible? And also, go ahead.
I would see it from two viewpoints. Developmental disorders, including autism, was not a priority for WHO till about 5 or 6 years ago. But based on the work of several people, we realized that developmental disorders are very common. They cause a very high amount of disability, and that disability very often can last throughout the person's lifetime, which accumulates into a very high amount of burden, not only for the people who have the disability, but also to their families and to society, and with large impact on all spheres, including economic sphere.
Sure.
So it became priority for us, and we have had some very good collaboration with the academic departments as well as with the NGOs like Autism Speaks, which have helped us a lot to put this very much high on the agenda. And fortunately, a number of countries are very interested and very committed toward this area. In fact, many of the first ladies and prime ministers and presidents routinely pay much more attention to autism than on many other areas of mental health, which in a way is very surprising,
Right.
because autism is an area where we do not know the cause usually. We also do not have a cure. Of course, there is a lot of care, but still the attention given is very large. And we're very pleased with that, because I think this connects us to the overall area of disabilities, but also the area of early child development, because developmental disabilities and delays are on a continuum with the normal development. And we believe that the normal development of children needs to be encouraged by various policy measures, and that will be of fundamental importance to the human capacity within that community over a long period of time. We know that millions of children are under threat from developmental delays, disabilities, and disorders. And although there could be some causes for that which cannot be changed with the existing knowledge, but there are many others which can be very easily and at very small cost can be actually averted.
Right.
Stunting can be avoided, nutrition can be improved, early child stimulation can be delivered, and we know how to do that, and still we are not doing that. So
Well, we're going into an area now, I think, in this discussion that I think is very important and might be something that might be relevant for child psychiatry in the future as well. Because I was in a meeting recently in the Middle East somewhere, and I won't go into details, but they were talking about screening for autism and early intervention, very important. But as we scratch
No intervention.
early intervention,
Oh,
early intervention and
Yeah.
screening and diagnosis and
Yeah.
early intervention, very important.
Okay.
But one of the things that we learned as we discussed this further was that there was no neonatal screening. So, for example, they were not doing PKU screening, where if you could identify and provide the right diet early, you could actually prevent. And this is something that Leon talked about a lot in his writings. In fact, you read some of his papers where he talks about these specific genetic conditions that preventable. He used to say, well, there are very few preventable causes in psychiatry, and there are, like PKU is one of them, for example.
and iodine deficiencies are another.
Iodine deficiency, many nutritional factors, stunting you mentioned,
Yep.
and then there are these genetic disorders, and then Tay-Sachs and others that he was talking about, and he had some amazing knowledge about these things. But we are not doing much about that, where we actually know that there's a whole history of that going on in neurodevelopmental disability prevention, very early, beginning from pregnancy and neonatal development, and integrating that into the autism era sort of a movement, which is very important. So this is something that I think brings me to this point of there are many neurodevelopmental disorders. They're not just disabilities, because we know as the world, we're getting into this genomics era where we're identifying many conditions that we will be able to I think it's getting much cheaper and cheaper as we move along, identify certain conditions that maybe we can try to do more prevention. And I think this is a very important transformation in medicine in the future. And so I wanted to know, because I think in the WHO ICD-11, for example, the APA had adopted the intellectual developmental disorders classification, as opposed to looking at intellectual disability as a disability, because intellectual disability actually is just a cutoff,
Yep.
which is based on adaptive or cognitive functions. But there is a huge area, including this area of intellectual disability that's not classified, like just borderline intellectual functioning and very poor adaptive functioning. As we make such progress in society, those individuals are left behind, and many of them need really help. So there is a need for a more broader framework for neurodevelopmental, where autism is one of it, included in it, but there are all sorts of other things to address these very early preventable causes of neurodevelopmental
I completely
disorders.
agree with you. In fact, WHO's view is that we need to take the overall area of child development as a single entity. And we know that there will be a normative distribution within that. And some children will have definite causes and disorders for them not developing in a suitable way. And we need to find the cause. And if we can do something about it by early screening, by averting that, we must do that, because disabilities need to be prevented. But overall, there will be other children who will have a developmental delay or disability, which we do not know the cause for. But still we know how to get their development on track as quickly as possible. And again, early identification will help in that. WHO has, and also at the extreme, there are children who will develop well unless there are threats. And we need to remove those threats, whether physical threat or environmental threat or social threats. You know, currently we are living in an age where there are so many children who have to migrate. They are refugees, there are internal migrations, and also people who suffer from natural disasters. And children are the ones who will suffer the most, because even a couple of years of life without education, without proper nutrition, without the social encouragement that they have, will affect their whole development throughout life. And so those are the threats that we need to be very aware of and prevent as much possible. But if not prevent, look after, so that the development can proceed as best as possible. So we see it as a continuum. And here I want to make another point, that although autism has attracted a lot of public attention, there are other developmental disabilities which have not. The intellectual disability that we have known for a very long time, even before autism became a prevalent diagnosis, is something that we are ignoring. And that is also a very large number of children who suffer from unidentified intellectual disabilities of all kinds, which we need to put within the developmental disabilities and disorders so that we don't ignore them.
Well, that's why the definition, I think, was intellectual developmental disorders, the idea that, or developmentals of intellectual, disorders of intellectual development, which I think is what the ICD-11 is saying. But I think that's a very good paradigm to address these issues, like take them one by one as we get more knowledge about it.
Absolutely. And I also want to make a point that we have two classifications, the International Classification of Diseases,
the ICF,
and also the ICF, which is much more focused on the disability part of it, as to which cognitive area the disability is and what can be done about that. So that's equally important.
That's the International Classification of Functioning. So I want to also give tribute to NIMH, because I think they've done incredible amount of work in the last few years and in global mental health and supporting many programs, and particularly the U programs in implementation science, and Dr. Collins, of course, and that's Pamela Collins I'm talking about, and also the NIH doctor, a good director, a good friend of Carola, Francis Collins. But you were at the meeting, and I think we'll wrap up on this, but you were at the meeting at NIMH yesterday, met the new director, and tell us about how do you see things evolving in the future? I mean, we have different, of course you can't make any political statements, but in terms of how you see the WHO mental health 2013-2020 policy going forward?
NIH, and especially the NIMH branch of NIH, has made a very significant contribution to global mental health, and we have extremely good relations with them. We have worked together for improving the global mental health situation. My close colleague, Dr. Pamela Collins, have been leading this effort, and we have been very successful in working together to increase the attention given to global mental health and also increase the research capacity within the countries. Their project on the hubs has been very successful,
right.
And I was very fortunate to be there yesterday with them for their 8th annual meeting on global mental health, where the new director of, not so new director of NIMH now, was also present and made some very forward-looking statements on
Dr. Joshua Gordon. Yeah.
the Dr. Gordon, and he very clearly enunciated that this area of work is extremely important for NIMH and will continue to work on that. We also have other players who have played a very, very important role in that. I would like to mention the Grand Challenges Canada, which has put in more than 40 million Canadian dollars in this area in the last 5 years and has created the kind of capacity for innovation within low and middle income countries that wasn't seen earlier. So there are a number of projects, a number of initiatives which are going forward, and that brings me to the point that I made earlier, that innovations done wherever in the world is a public gain, because anybody else sitting in any other part of the world can read that, can experience, and then apply it in their setting, of course with proper adaptation. But that's a net knowledge increase that we need. And some of these institutions like NIMH and GCC have really worked very hard to start that process of innovation and the thinking of innovation, which is extremely important in an area. WHO, the organization that I work for, is a public health agency. And we work very closely with the research agencies like NIMH because there is a lot of synergies, there are a lot of gains to be done working with them, and also with other research organizations within other countries. But having said that, I must say what I said earlier, there is still a need for much more international collaboration, much more global collaboration, because that's where the gains will be much, much larger.
Well, I think in that sense, I want to add as a tribute, continuing tribute also to the Fogarty International Center, because of this incredible innovation in the way that they approach brain and disorders and behavior over this more than a decade of their funded programs, and the R21 and the R01 programs, and the ICORDA program and the non-communicable disease collaborations, and in building capacity in many of these countries, and the emphasis on interdisciplinary research in mental health, which I think Leon Eisenberg greatly valued. He sees this basic sciences of psychiatry is really this public health, epidemiology, biostatistics, but also genetics and all sorts of other things which cross-play in these areas. And there's tremendous gains to be made with this convergence of these different approaches, especially from a scientific point of view.
Absolutely. This capacity building is so important. You don't give a hungry person a fish. You teach him how to fish.
Right.
That's going to be really the key message. And I think that's where capacity building, especially by those centers which have a lot of experience in this area, can be very, very instrumental. And in that sense, Harvard, being active in this area for a very long time, is in a very good situation to really start that kind of collaboration and increase capacity for research in many countries.
Well, on that proverb, which I'm sure exists in maybe more than 80 countries, which is really true. I want to thank you because I think that you represent what we wanted to do in this award, which is that a person, an individual who selects to make a huge lifetime commitment to a field where his influence is really goes beyond the boundaries of the department, beyond the call of duty, to make a significant impact in human experience and how we treat other people, and as part of our mission in health and global health is the area that you focused on, which I think is very much resonates with Leon's view of, and he had so many friends all over the world. You mentioned David Goldberg. He was a very good friend of David Goldberg, and then I can give many other names. And so I want to end on that. Thank you very much for that, and thank you very much, Carola, for hosting us today, and we very much appreciate this opportunity.
I want to thank as well, first of you, for all of you to come, to arrange all this wonderful afternoon, and also because in addition to names that I remember with great affection, some of them will be there tonight, you give hopes for the students that would like to, in the future, get into your field and my ex-field, because in the old days you used to say only the very bright students and the worst students go into psychiatry. And because, of course, they didn't have to know medicine for the worst students, and the ones that had hope had to struggle with all kinds of difficulties. And you give hope for the very good students that would like to go, and that things are a little bit better for future psychiatrists. Thank you. You also took me back to the back times when all of these names were so familiar, and all of those programs. And in fact, my doctoral thesis was in a subject you mentioned today, when I knew nothing or very little about Tay-Sachs disease. I started with that when I knew nothing but one patient that had Tay-Sachs disease, and it's worth nothing now. But thank you, your presentation was wonderful. Now I will have to feel so sorry because I'm not going tonight. But thank you very, very much to both of you. Thank you.
That was your dissertation, right? The Tay-Sachs disease?
Yes.
Yes.
I want to thank Carola. You and Leon have really led this area for a very long time, and we still derive inspirations from your work and Leon's work. And thank you, Karim, for this award, as well as for talking to me, because it has brought out a number of issues which are extremely important for you and also me.
Well, the pleasure is ours, and I want to thank Dr. David Klein from the American Academy of Child Psychiatry, who essentially has been influential in inspiring these interviews, which I think has been something that we would like to continue but learn from. And we learned a lot from you today, and thank you very much again.